Ay, 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 ay. Yeah. Mm. Mm.
Hey, Ben. Hello, Ben. You there?
Hello.
Good morning, Adele.
Good morning, John. How are you doing?
Good, how are you?
Great. Do you see me okay?
Hold on, don't have my camera on. There we go. So the Boston boy comes back to China.
There you go. I've been there a number of times. I went to the ocean meeting there, which is the
Oh, more than once, huh? I thought you were there just once.
No, I went there in 2012 for quite a number of times, maybe 4 times or so.
Oh,
I
okay.
visited a number of times, and I don't think I met the.
Yeah, Ben is on a flight to Malaysia, but he checked in about an hour ago, so I think he's he'll be able to come in, I believe.
Okay, wonderful, great. Let me work a little bit, do a few final touches on my talk.
Yeah, you want to test something?
It should be straightforward. We can.
Yeah, just put.
Yeah, I'll share my screen. Just make sure.
Yeah, you have to share your screen and go to your video or go to the part that you're concerned about. Are you still there, Adele?
Yes, I'm here.
Oh,
Just doing a
okay.
few touches. Okay, let me see. Video. Okay. First, put the screens. And then, now, am I able to share the screen right now, or?
Yeah, you can do it now, yeah.
I'm not showing up with a share screen button. I just have like a web.
Yeah, just like you did it in Jacksonville.
I just don't have the the button in the way that I logged in doesn't give me the I don't have a share screen. I look like I'm just a webinar.
Or are you using the same computer that you presented to Jacksonville?
No, it's a
A
little
different computer? Is it at the hospital?
Yeah.
Do you have the latest Zoom installed?
I do.
And there's no share screen option at the bottom?
There isn't one. Should I log out and log back in?
Yeah, try that first. That's the first. Completely turn off your computer and come in. Oh, I don't think mine is up there. Okay, magic. Can you hear me? I think you're muted.
Okay,
Okay, make it presentation mode.
okay, very good. Let me,
Yeah, there we go. There we go.
okay, is that good now?
Yeah, Dr. Malik, people think I'm a genius with the computer, but all I say to them is reboot, and then it's fixed. I said, see?
It's magic.
95% of the problems are helped by rebooting. But I claim credit. I accept the credit.
And you should.
Yeah.
Okay, I'm just gonna log back in a few minutes then. Actually, I'm gonna stay online. I'm just gonna go on mute and stop the video share for a sec.
Okay. Okay, I'll be back.
Okay, great.
Hello, June Wang. Hello, June, are you there? June Wang? Hello. Good morning. Start in about 10 minutes. June, are you there? June Wang? Oh, he's in, okay. All right, Dr. Wang, how are you? How are you doing, Dr. Wang? Can you hear me okay?
Okay, I can guide you.
Okay, good, good. How are you?
Thank you. Thank you.
Well, welcome.
You're welcome.
You're familiar with Zoom and everything, right?
Yeah,
Yeah. You do a lot of Zoom.
I will deliver my presentations after you.
Okay,
So you can go first.
okay. We'll start in about, I think, Dr. Malik is going first, okay?
Okay. Mhm.
Hello?
Hello. Hey, Martin, how you doing? Is your camera working today? Martin?
What's this? Okay. Can you hear me?
Yeah, is this Martin?
Yeah, it's me speaking.
How you
Hey,
doing?
John, good to see you.
Okay, well, your camera's not on yet.
Yeah, I'm trying to switch it on 1 minute. All right.
Oh, there you are. There you are. Yeah.
Yeah, hi.
Okay. It looks like you're relaxing.
Yes, I have to relax a little bit. I lifted some heavy stuff, and okay, let me mute. I'm getting a call here.
Okay, excuse me, Martin. Hey, Wan Lee.
Hi, yeah, John, yeah.
I
I'm here.
was getting nervous.
Bing Shi, Dr. Shi, he told me he's in the flight from Shanghai to Malaysia.
Yeah.
Yeah.
No, I
So-
saw him. He came in early, but he
Oh,
left. He was just there for 5 minutes, then he left. So. I don't know.
yeah, he told me he will be on the flight. So yeah,
Okay. Okay, so I'll introduce you, then you introduce Dr. Malik, okay?
yeah, I can do it.
And you run the show.
Uh,
He's been to China a couple of times, 4 times. Have you ever met him?
You mean,
He's in cerebral
Dr. John.
vascular he's from Tufts University. Dr. Malik, are you there?
Yes, I'm here. Thank you, John.
Yeah, this is Wan Lee. He's going to be introducing you. He's the head of cerebral vascular surgery at Beijing Tiantan Hospital in Beijing.
Nice to meet you, Dr.
Hi.
John.
yeah. Actually, I think you last time you talked this e-shunt for the OCIM meeting, right?
Probably WFITN. The last ocean
Yeah,
meeting.
WFITN, the endovascular meeting.
Yes. The last ocean meeting I attended was in, I think, 2020.
Okay.
That was.
Okay, you ready, Wan Lee? You ready to go, Wan Lee?
Yeah, and
Okay,
we have.
okay. Let me introduce you first. Okay, let me introduce you first, Wan Lee. Okay, hold on.
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the honor of hosting the China Neurosurgical Journal webcast, a bi-monthly with special guest Adele Malik, MD, and I'll let Wan Lee Zhao, the head of cerebral vascular surgery at Beijing Tiantan Hospital in Beijing, introduce Dr. Malik. Welcome, Wan Lee.
Thank you, John. Hello, good morning, good evening, good afternoon, everyone all around the world. So welcome to this Chinese Neurosurgical Journal webinar cooperated with the Neurosurgical TV organized by Dr. John Burnett. So today we have 2 very interesting topics. The one is about an e-shunt system will be presented by Dr. Adel Malik from Tufts University Medical Center from Boston, Massachusetts. And the second topic will be about the network, neural network surgery talk by the Dr. Wang from Nanfang Medical University, Nanfang Hospital. So the first speaker will be Dr. Adil Malik. He's the Chief Neurovascular Surgery Director of Taft Medical Center, Boston, Massachusetts, and he will talk about endovascular treatment of communicating hydrocephalus. It's a very interesting topic. Introduce e-shunt system to treat the hydrocephalus. So please welcome Dr. Malik.
Thank you very much, Dr. Zhao. It's an honor to be able to present to you. I had the honor of visiting your wonderful hospital and your hospitality at the last Ocean meeting. So today I wanted to give you a little bit of an overview on what we've been working on for a number of years now, which is a novel way to treat communicating hydrocephalus that involves an endovascular approach. These are my disclosures. So the field of endovascular intervention has really undergone a revolution in the last 20 years, and our favorite procedure of microsurgical clipping has been over time supplemented and then in some cases replaced by a less invasive approach for treatment of aneurysms using initially coiling, stent coiling, flow diversion, and other intracellular devices. We also have made significant improvement in the treatment of other aspects of cerebrovascular disease, of course, with stroke intervention, but also for treatment of idiopathic intracranial hypertension, for example, with this venous stenting approach. And this really brought a discussion between me and my colleague and partner at Tufts Medical Center, Dr. Carl Hammond, about possibly offering treatment for communicating hydrocephalus. As you know, hydrocephalus is a very common condition. It results in increased pressure, which often requires urgent treatment. You can see the dilated ventricle with a transependymal flow. And there are, of course, two versions of hydrocephalus, communicating hydrocephalus, which is the most common condition, and obstructive hydrocephalus, which is not going to be addressed today. So this approach is mostly for communicating hydrocephalus, which forms close to 80% of all cases. So as you know, ventricular peritoneal shunting has been a standard of care for many years and really has provided the safety and ability to treat hydrocephalus in a simple way. However, it is a procedure that has not resulted in significant innovation over the last number of years, and it can be fraught with a number of complications, including intracranial hemorrhage from the passage of the catheter, hygromas from overdrainage, and this is a result of the fact that there's a column of fluid which prevents a siphoning effect, which causes a siphoning effect when the patient gets up. And even with changes in the valve with placement of an anti-siphon device, this remains a risk, especially in older patients. Catheter misplacement, which can occur, slit ventricles, which makes targeting the very small space of the frontal horn very difficult, and of course, peritoneal catheter malfunction and infection. In fact, recent studies have shown that over the past number of years, there have been very few advances or improvements in the overall shunt revision rate, which can be upwards of 40% in many cases. And so our hope was to provide a new innovation and an alternate approach to treatment of hydrocephalus. And the thought was if we could mimic the arachnoid granulation, which is the small structure that reabsorbs cerebrospinal fluid and filters it back into the venous system, and we could actually get a mechanism of hydrocephalus, which would be mimicking, or if you will, simulating the actual natural function of the arachidonogranulation. So these were some initial thoughts between Dr. Ham and myself at connecting potentially through one of the sinuses into the adjacent cistern to actually drain CSF. As part of this effort, thanks to the help of the Office of Innovation at Tufts University, we were able to partner with a superb team of business development professionals who have had a track record with Dr. Levangie and Pat Sullivan and their colleagues, and a company was formed that was able to begin the design and work on this device. And so this is where we are at this point. We are able to actually connect the inferior petrosal sinus to the adjacent cistern, which contains the fluid. This is shown as a schematic here, where you can see that we want to drain the cerebrospinal fluid from the cerebellopontine angle cistern into the inferior petrosal sinus. And the reason to choose the inferior petrosal sinus is that it's a stable venous pathway that is accessible, that all of our neurointerventional and neurosurgeons have great experience reaching during petrosal sinus sampling. And it's also one that is redundant and, of course, less dangerous than potentially a sigmoid or transverse sinus in terms of injury or any kind of flow arrest during the procedure, potentially. This is the design of the device. It is actually a very small tube that measures approximately 3 centimeters in length. Is made of carbosil, which is heparin coated, has a nitinol little malachite or little star, if you will, that helps keep the device in place inside the cistern. And the lumen itself enables the passage of the cerebrospinal fluid. Although it's a small lumen, actually you'll see, because it's a very short distance, there is very low hydraulic resistance, and actually the fluid flows very nicely. And the other bonus of that is, because the lumen is small, at any set volume flow rate, the velocity of the fluid is quite high, and we believe that helps prevent sludging and stasis of proteinaceous material, as you would get, for instance, in a valve, which is just sitting there. This is the blue fluid that you see here is from the high pressure, and there's actually a slit valve that prevents backflow. So when you have an elevated jugular venous pressure, when you're bearing down or coughing, if there's a transient elevation in that pressure, this valve will prevent the backflow. And this is what the device looks like in real life. And so the approach then was to devise a delivery technique and approach to place the e-shunt implant across the dura percutaneously, so that we connect the cistern adjacent to the inferior petrosal sinus. The cistern is right in front of the pons, the cerebellopontine junction. Basically it would drain into the jugular venous system. This is, of course, applicable in patients that have normal jugular venous pressure, in patients that have the fistula or a venous stenosis, or if they have abnormally elevated central venous pressure, then this may not be very useful. The system that we devised involves using an off-the-shelf 6 French guide catheter, advancing with an 027 microcatheter, and selecting the distal IPS and the cavernous sinus, where we deploy a small anchor that has a very, very low profile flat rail, and that enables us to advance the delivery catheter, which rides in rapid exchange fashion over the flat rail. And then this has a system that is covered, a needle that is covered until we get into the target site where the needle is unsheathed, and we are able to advance through the dura into the cistern. The e-shunt is preloaded within the needle, and then it can actually be advanced in a controlled fashion into the cistern. We are leveraging one of the features of the inferior petrosal sinus is that it makes an angle. This is very useful because it enables us to actually go beyond the angle. And as we unsheath, the system straightens up, and then you are able to effect a controlled advancement through the dura into the cistern. The system itself it has a flat trail at a certain depth, and that prevents over penetration in case of poor technique. Also, the e-shunt is within a shroud, which is a micro stent that enables fine control until the final release step. And so for selection of patients, it involves pre-treatment, pre-procedural imaging, which we use a MRI currently with a gadolinium enhancement and a regular CT. The regular CT enables us to see if there's any bony overhang, which may prevent the successful passage. And the MRI enables us to visualize the size of the channel in multiplanar reconstruction. And currently, we're also performing segmentation, so we can actually see the venous pathway, the cavernous sinus, inferior petrosal sinus, as well as the arteries. There's usually a ICA loop, and we have to make sure that it is not too close to the access site. This screening technique can be simplified by just performing a CTA and a delayed phase CTV. But currently, we are relying on this earlier generation approach. In the Angio suite, we have been leveraging 3D road mapping, which, as you know, is a feature that's available in most of the angiography suites, but I have not personally used it until we came to this solving this clinical problem, which is the delivery in 3D space of our device. And so once the microcatheter as part of the deployment system is in the cavernous sinus, we do a gentle injection and acquire a 3D cone beam CT or 3D rotational venogram. And then we select that site where we want to access. As you can see again, that IPS comes up and then goes up the clivus towards the cavernous sinus. And this is exactly the site where we want to exit, usually the midpoint of the jugular tubercle. And so this is a site that we can select. And then once that selection is performed, it is sent over to the 3D workstation. And then we actually are able to move in 3D space and we know our target. So the target site in orange here is the inferior petrosal sinus. And you can see that we go beyond and then unsheath. And then you can see that this is the access needle. We are able to exit in a controlled fashion outside the IPS and enter the cerebellopontine angle cistern. And you can see this is the actual needle in a cadaver testing. And the cone beam CT shows a flat trail, as you can see in the IPS. And that also tells you the feature of the flat trail prevents undue advancement of the needle in this critical spot. So this is just an illustration of the approach. You select the target on the cone beam. You basically send it to the 3D roadmap. This is the anchor being deployed. And then the delivery system going beyond, unsheathing the needle, pulling back, and then advancing through the IPS into the CP angle cistern, at which point the preloaded e-shunt device is advanced and pulled back and tucked in, and then we can retrieve the anchor. This is what the device looks like in position. This is what it looks like on the 3D roadmap flat plane. We can do it on one side or both sides, potentially bilaterally. And then it can also be removed. We can remove the e-shunt device with a conventional snare. You can see here the snare after deployment, grabbing the proximal part, the radio opaque proximal mark, and then pulling gently. And you can actually have the If you look at the malachite, it will collapse. And basically the dura is self-sealing. And what's useful here is that the gradient of pressure is higher on the cerebrospinal side than on the venous side. So there's less chance for bleeding to be occurring by venous blood entering the CSF. So our next strategy was to begin a clinical trial. And for this, we partnered with my colleague and dear friend, Dr. Pedro Lilic at Buenos Aires in Argentina. We had the chance to have Dr. Lilic visit us in Boston, and we visited Dr. Lilic at Clínica Sagrada Familia at the Inner Institute. And the initial study was to actually focus on patients that had subarachnoid hemorrhage, which, as you know, results in many cases in communicating hydrocephalus. And many of these patients have a temporary external ventricular drain that is placed that removes the blood in the CSF and relieves the high pressure. But after a period of time, when time comes to remove the ventricular drain, usually a weaning process occurs when we clamp the EVD. Most patients tolerate this if they're low grade, but many patients do not and end up requiring a permanent VP shunts. It is those patients that we included in the study. So for patients that failed a weaning of the EVD, we actually include them in the study. This is the first in human patient and a lady who presented with a ruptured MCA aneurysm. You can see the blood in the ventricle, and she developed hydrocephalus, and the EVD could not be weaned. This is before and after treatment by Dr. Lilic's team. And so the ventricular drain has a pressure sensor that enables measurements of the pressure. And this is the clamp test. You can see she could not tolerate it because her pressure shot up to over 30 centimeters of water. And as a result, she was enrolled in the e-shunt. And this is a pre-procedural imaging showing the MRI, and we can confirm the depth of the cistern to ensure safety. Currently, we require greater than 5 millimeters. The multiplanar reconstruction shows us very nicely the inferior petrosal sinus path. And then this is the rendering showing us the IPS and then a loop of ICA. And then we have greater than 5 millimeter distance. And this is the actual procedure, as you can see here. You can see Dr. Lilic is actually, as the anchor deployed here, has already gone past the ideal site and now has unsheathed the needle and is actually pulling back to get that ideal angle. As you can see, the system straightens up, and now we have the ability to advance. And so the needle now is being advanced again percutaneously. And then they actually did the venogram to confirm that there's actually no contrast leaking into the cistern. At this point, the e-shunt system was advanced, and you can see the malachite opens up and then flops into the space. At this point, the needle is pulled back in a controlled fashion and left in position. This is what happened to the patient's intracranial pressure overnight. It actually came down very nicely. So in the morning, her pressure was 6 millimeters of mercury, around 8 centimeters of water. And this is with the EVD clamped. So this confirms that the system is working because it was able to decrease the ICP in consistent fashion with the ventricular drain clamped. This is the imaging of the e-shunt implant, and you can actually follow it on the cone beam CT from the cerebellopontine angle cistern through the IPS into the jugular vein. So this is what the tracing looked like in that first patient. And again, if you think of it, we were able to percutaneously with a catheter technique enter into the central nervous system safely. She had a CAT scan showing no hemorrhage right after the procedure on the table using cone beam CT, but also on the next day. After the ICP was kept low, being transduced by the clamped EVD, the E-shunt basically was removed. I apologize, the external ventricular drain was removed. And so this is the primary endpoint, which is maintaining the ICP after placement of the E-shunt under 20 centimeters of water consistently, and enabling the removal of the external ventricular drain. This has been performed in actually 7 more cases now, so we have a total of 8. And then you can see there's a consistent, steady decrease in the pressure, obviously with some variations when the patient is being moved or turned. But when you look at the average of those first 7 patients, this does not include the last one, you'll see there's a very rapid decrease in the ICP and maintenance around 10 centimeters of water. This is highly statistically significant and happens very quickly, and then shows a slow trend down to around the value of 9 centimeters of water at the time of removal of the drain. So this is treatment of hydrocephalus, communicating hydrocephalus after subarachnoid hemorrhage, enabled us to have a proof of concept and show that the E-shunt can be used in a strategy to control post-subarachnoid hemorrhage communicating hydrocephalus. There are other conditions of hydrocephalus, as you know, and elevated intracranial pressure. One of them is idiopathic intracranial hypertension, which is being diagnosed increasingly, certainly in the United States. And many times results from a stenosis or narrowing of the transverse or transverse sigmoid sinus junction, often as a result of a herniation of a arachnoid granulation. And this stenosis results in elevated venous pressure upstream, which then increases the intracranial pressure and then acts as a vicious cycle, potentially causing further stenosis. And obviously, one technique to break this cycle is to treat medically with Diamox or carbonic anhydrase inhibitor that would decrease the CSF pressure and hopefully decrease that stenosis. Few patients tolerate that, but it's a first line treatment. The other technique, which we have been using increasingly, is to place a venous stent. My technique utilizes a long construct so that we cover from the trochlea all the way to the sigmoid sinus. When we use shorter constructs, we noticed stent adjacent stenosis. And now that we've used these long 8 centimeter stents, we have no longer seen this complication. But in this particular case, because the E-shunt implant proximal portion actually drains in this area, this is the area of low pressure in most patients. The pressure is elevated here, and there's usually a gradient. We usually require a gradient of higher than anywhere from 7 to 9 millimeters of mercury, depending on the patient's symptoms, to offer stenting. And so this pressure would be significantly lower. This is actually a patient that presented to Dr. Lilik with long-standing idiopathic intracranial hypertension. And you can see the swelling around the optic nerves, as well as the stenosis of the transverse sigmoid junction. And this patient did not want to have a regular shunt placed and could no longer tolerate medical therapy and was offered an E-shunt under compassionate use. And this is the actual inferior petrosal sinus path on the MRI. This is the in-procedural imaging showing the cavernous sinus, inferior petrosal sinus, and you can actually see the access needle aspect of the delivery catheter. And this is the Malacot. You can see the Malacot being delivered. And this is the 30-day follow-up. The patient's symptoms improved. His headache, he's been headache-free. You can actually see the swelling has gone away around his optic nerve when you compare it to pre-op. And this is a cysternography that the team in Buenos Aires performed, and you can see the Malacot, and you can actually follow the contrast. And the gadolinium is actually filling the IJV, internal jugular vein, on the side of the e-shunt, but not on the other side, confirming patency of the device. The condition that we have been quite interested in treatment involves normal pressure hydrocephalus. It's a condition that involves a large proportion of our older patients who develop dementia, have an impaired gait and urinary inability to control their bladder. And it involves, it affects a huge patient population and has significant social costs. If you think of how it affects the patients' families, and many of these patients wind up in nursing homes. This is a nice case study that was published in the New England Journal of Medicine, and I show it to you mainly because they have a very nice video of the patient pre-procedural. You can see the shuffling gait. She's requiring assistance to walk. And she actually underwent a VP shunt, conventional VP shunt by the team at Mass General. And this is after her VP shunt early on. You can see she's already able to walk better and faster. She's standing up more upright. And this is a little bit later. You can see that it's a completely different person. She's able to walk on her own in controlled fashion, and basically her life has been transformed for the better. And so we have wanted to see if we can offer e-shunt implant for this patient subset because they are older and usually have a higher rate of complication with conventional VP shunt surgery. And so this is an NPH pilot study that was initiated first in Buenos Aires with Dr. Lilik's team, and more recently in the United States. And I will be showing you those results. And it involves screening patients to see if they're what's called a timed up and go test. It's a timed test where the patient is sitting on a chair. They're asked to stand up, walk down 3 meters, turn around, and sit back down. And that length of time that it takes to perform this test is actually measured. So one of the ways that NPH patient or normal pressure hydrocephalus patient are screened is they undergo a lumbar puncture with a high volume tap. And if their gait improves significantly, in this case, we required a 20% improvement, then they were enrolled in the trial. This is the first patient, 74-year-old with gait instability, urinary incontinence, and also cognitive impairment. We measured the bladder symptoms with a questionnaire and the cognitive impairment using a Montreal cognitive assessment tool, the MoCA tool. This is the patient's inferior petrosal sinus, and then again, checking again for the anatomical perspective. And this is the procedure site. This is a 3D road mapping on the Philips system, which is a little different than the one I showed you with the orange dots on the Siemens we use here. And then beautiful imaging from the Buenos Aires team. You can see the Malacot being deployed. This is the e-shunt. And then you can actually see the Malacot and then the path down to the jugular vein. At 30-day follow-up, you can actually trace the e-shunt, and this is again a cysternography showing patency and signal in the ipsilateral to the e-shunt jugular vein.
Hello, hello.
Yeah, hello.
Good morning.
Good morning.
Sorry, I'm the official party pooper. I gotta stop the socializing and start to work. Good morning, everybody. A beautiful, beautiful day ahead of us with a lot of great speakers, all the way from different countries like Iowa and Massachusetts. If you like that, I got
Okay.
To start today, we have our
Dr. John, I think this is a little All right, here we go. So the gait instability in the tuck test improved. At follow-up, there was an improvement in both the gait, in the urinary incontinence, as well as the Montreal cognitive testing tool. This is the patient before on the left. And this is the patient after the e-shunt placement on the right. You can compare the velocity of the gait. He was able to stand up, walk around, and sit back down. So significant improvement. These are the numbers that we saw in this very first patient. And since then, we actually have also began the pilot study in the United States and partnered with Dr. Charles Matuk at New Haven Hospital at Yale in Connecticut. This is their actual e-shunt procedure being performed, and also with Dr. Adnan Siddiqui at SUNY in Buffalo, New York. And this is an initial summary of the patients at the 90-day and 180-day visit. And you can see that except for a few patients, patient 5 and 12, all of them have had significant improvements in most, if not all, and all of them have passed the primary endpoint, which is improvement in at least one of these 3 outcome measures. When we analyze with statistics and look at the timed up and go test, we can see that at 30-day, 90-day, and 180-day, there is a significant improvement in the gait with p value less than 0.05 when the patient is followed compared to their baseline pre-treatment. When we use a composite of the TUG, the bladder symptoms, and the MoCA categorized in terms of mild impairment, significant impairment, and no impairment in cognitive function, we can see that there is a highly significant improvement in the composite score. So we think that this tool hopefully is able to provide a low-invasive solution for treatment of normal pressure hydrocephalus in this elderly population. So far, the clinical trial progress, we're in a situation where we have had 25 e-shunt devices implanted, both in Argentina but in the US with Dr. Matuk and Dr. Siddiqui. All of the primary endpoints have been reached in these patients. There's been no instance of procedural or delayed hemorrhage, either subarachnoid or intraparenchymal. And we've also had some very powerful testimonial from these patients and their families. Of course, we are still in the early stages as we determine the long-term durability and safety of the device. This approach also provides another method of delivering pharmacological agents. We can, using the same delivery system, deliver either a single dose or multiple doses to the central nervous system. This can be useful for treatment using gene therapy or other cell-based therapy, stem cell potentially, or other pharmacological approaches without requiring drilling of a hole in the skull or relying on a lumbar tap, because as you know, a lot of these gene therapy approaches, if you use a lumbar approach, has a lot of local concentration, but very little reaches the brain. So in conclusion, percutaneous endovascular transdermal access to the central nervous system has been shown with the e-shunt approach with Ceravasc to be feasible, safe, and reproducible, now with 25 implants. Transdural venous to cisternal puncture can be performed safely using 3D imaging and planning. And the concept of CP angle cistern to internal jugular CSF shunting appears to yield very good results for communicating hydrocephalus, which appears sustained clinically. We are continuing to follow our patients. We have had our first 365 one-year follow-up day for our normal pressure hydrocephalus and our subarachnoid hemorrhage patients, and they are both doing well. And those early results, I tried to show you that this approach, akin to a small biomimetic endovascular delivery, is able to offer a solution potentially for both subarachnoid-related communicating hydrocephalus, but also idiopathic intracranial hypertension and normal pressure hydrocephalus, which affects the elderly population. And this platform may have applications in other areas of neurosurgery. And I think this is very exciting for us endovascular interventionalists because it offers another less invasive approach for reaching the central nervous system. So with this, I want to thank you very much for the invitation and for the honor to connect with our physicians in China and in Asia. And thank you very much, John, for enabling us to again connect the world as you have been for the last few years. It's really an honor, and thank you.
Thank you.
Thank you, Dr. Malik. I think you can give us a
when it's appropriate, but most importantly, reassure people.
I'm sorry, we're getting
So
some
before a
interference
doctor
again.
can
I'm sorry, I'm having a hard time hearing.
Yeah, trying to find out where that's coming from, huh?
The brain is supplied by our four major vessels that join together, forming that circle of Willis, which is at the base of the brain, with the anterior cerebral artery, the posterior cerebral artery, the internal carotid, and the basilar artery. Now, this has always been
Mic open, I'm not catching the, does anybody have an extra mic open? I'm gonna mute you just for a second, Dr. Malik. Yeah, it's coming from your computer, Dr. Malik. That's okay, that's okay. Okay, go ahead.
Thank you, Dr. Malik. Yeah, now I think you give us a very interesting presentation. I'm sure there are many questions concerned about this e-shunt system. So there are some questions from the audience ask about the pressure control valve and also the long-term effect after implantation. So can you give us a little bit more explanation about it? I mean, you mentioned about the pressure difference between the vein and the CSF space. So can you give
Very
us
good question. And so the design of the e-shunt was such as to allow the drainage of about 10 cc's of CSF at a pressure differential of 5 millimeters of mercury. And so the need for pressure regulation that we see in a regular valve when we think of setting the valve at medial, low, medium, or high, or using of an adjustable valve, really is the result of having to connect the intracranial pressure to the abdominal pressure and two systems that are not really designed to be connected together. For this particular system, you are effectively draining only when there is an elevated pressure. And then when that pressure goes down, the drainage stops. And so that's basically what's occurring. You have a cracking pressure by virtue of the valve system. And then after the CSF decreases, it stops. So it's kind of like a resistor that allows the drainage fluid. And then when the pressure elevation is small, it stops. There is no sensitivity to patient positioning. And so we don't see that over drainage phenomenon that you would basically observe in patients with a conventional shunt. In terms of long-term effectiveness, we've had cysternography, like I showed you, up to 90 days, but the clinical results from the MPH study seem to be holding at 180, and then we have a patient at 365, so 1 year. So we continue to accumulate this data. In terms of what do we think is the overall effectiveness and how can it flow through some small plot like this, as I mentioned, because it's relatively small and short, when the CSF flows, the velocity of the CSF is pretty high through the tubing. And so there is no sense of stasis of the cerebrospinal fluid like you would get in a valve chamber or a very long tubing that you get in a regular VP shunt. And I think that that is a positive contribution of the design.
Okay, thank you. Thank you. Are there any questions from the?
Yes, I believe Harshad Parekh, a neurosurgeon from Mumbai, India. Harshad, are you there?
Hi, John. Yes, I'm there.
Go ahead, Harshad.
It's excellent presentation and wonderful technique you've shown. Something is very, very different than what we do normally. I just wanted to come to know what are the criteria you select these patients for an e-shunt. What means all patients can be subjected for an e-shunt who requires a VP shunt, or there are some definite criteria. Okay, 1, 2, 3, this will be benefited by e-shunt rather than a VP shunt.
Of course.
In long term, this VP shunt will be replaced by e-shunt. Do you think so?
Thank you very much, Harshad, for this excellent question. So as you know, right now we are in the research phase. So we are enrolling patients that are interested in having the e-shunt instead of a conventional VP shunt. But I think the first question is any patient that has communicating hydrocephalus that has the anatomy that enables this technique, meaning absence of bony overhang and good venous anatomy that's favorable. Based on our analysis, that should be more than 75% of patients with the current criteria. Of course, this is a first generation device, so we're hoping that with time, it may be possible to miniaturize the device further so it becomes usable in younger patients potentially with communicating hydrocephalus. Currently, this will not replace obstructive hydrocephalus because it doesn't resolve that problem. But you know, with time, it may be possible to use this transvenous approach to actually perform a third ventriculoscopy from below. But currently, with the device that is available today, I would say I tried to show you that it appears to work in 3 different etiologies of communicating hydrocephalus, and that it will be an endovascular tool. And I think, you know, its role overall may be anywhere from complementing to replacing the VP shunt in different patient populations. The one advantage is compared to comparing, for instance, coiling to clipping for aneurysms. When you coil or treat an aneurysm with an endovascular tool, many times it interferes with your treatment using microsurgical clipping because you have to deal with the implant. Luckily, the e-shunt approach is completely separate from conventional shunting, and so patients that already have a shunt can have an e-shunt without removal of the old VP shunt, and conversely, if you have an e-shunt and you have a complication that requires, for some reason, a placement of a conventional shunt, then the e-shunt does not interfere with that surgery. So I think that's one of the positive aspects of this approach. Its final role in treatment of hydrocephalus, of course, will be determined by the long-term results, but so far they've been encouraging. We have not had any delayed hemorrhage, delayed complications, or procedure-related hemorrhage, and so these are all, you know, positive kind of developments. I hope that answered the question.
Yeah, thank you. I was just wondering whether any patient of NPH or idiopathic non-operative hypertension can be taken for an e-shunt.
Okay, that's a great question. So as you know, we have been quite stringent in our selection. We have required a 20% improvement in the timed up and go test. So the gait has to improve by 20%. Now, as you know, from clinical practice, not everybody has such an improvement. So I don't know if the patients that only improve marginally will also benefit from the e-shunt, but that will have to be determined. You know, is it possible that the patients that show a 20% improvement also have elevated CSF pressure and would tend to benefit from e-shunt, whereas those that may have a weaker response may need a lower valve, if you will, and that can be done certainly by redesign of the implant, but just changing the features of the slit valve that is in the device without redesigning the entire approach. So currently we have just one middle of the road setting that we are using, but certainly it can be modified to make it more flow more with a lower path. So to be determined. So far, these are patients that have shown greater than 20% improvement in the velocity of their gait after the lumbar tap.
Thank you. Excellent presentation. Something fascinating. We are all struggling with the shunts.
Yes.
Conventional shunts. We are all struggling.
Yes, and this was really the motivation for this. You know, I mean, the anecdote is that my colleague Carl Heilman likes to joke that, you know, we took away the aneurysms, which was the most fun part of microsurgical, microneurosurgery. And he would love to stick us with the least fun part of neurosurgery, which is dealing with shunt malfunction, shunt revision, shunt infections, and so on. And in a way, that was part of the motivation, is to offer the same level of advancement that has been witnessed in endovascular treatment, you know, of aneurysms with the all the endovascular devices, the stents, coils, fluid diverters. And yet the VP shunt has been still using the same technique, albeit with adjustable valves, anti-siphon devices, which have improved the care, but in some ways also complicated it because they've introduced these paths of, well, let's just decrease your pressure. Do you feel better? Let's go up and so on. So the intent of the device of the e-shunt implant was to just have another approach that was more biomimetic, to kind of emulate the actual natural path.
Is it in market very easily available, this e-shunt implant?
I'm sorry, doctor.
Is it available easily?
Well, we are still in trials. It is not FDA approved at this point. We are about to begin a pivotal trial. So we're recruiting many centers, and we hope that once that pivotal trial, is performed, and hopefully if we continue to see the same results we're seeing here, we hope for a favorable decision. But we are nowhere at that point. But hope to be there, if we continue on the current path.
Thank you. Excellent.
Okay, Juan Lee, I think Martin has a question. He just looks like he's
can I say something?
Yes, go ahead, Martin.
The interventionalist conferences, you see them talking about this, and I think it's an important development. And it also goes to show that we don't, when we say we struggle with shunts, we actually not only struggle with shunts, but the whole idea of how the CSF circulation really works. We have a little bit limited knowledge, and nobody's really looking into it. And one option which I could see developing, apart from this very good idea that you utilize the pressure difference between the CSF space and the cranial venous pressure at the level of the head, is that we would actually start doing ventricular drains that then, via similar puncture into the sigmoid sinus, are connected to the sigmoid sinus. Advantage of this would be that it would be much easier to revise. Whereas I don't think you can do much revision if your E shunt fails. Basically, you're limited to just insert a VP shunt or maybe do whatever other procedure that is conventionally available. Did I get that right? Your salvage procedure would be a normal shunt.
So the salvage procedure in a site that does not offer e-shunt would be a normal shunt. So this is the idea, is that you could always place it. But this shunt can be removed. It can be removed and you can insert another one.
Yeah, I know. You
of course.
Have special retrieving things and like that. Yes, it's a very important development, and we hopefully we understand more of the pathophysiology. And let's not forget that there was always this idea that if you have a CSF problem, that you should actually go very close to where the CSF is coming from. In other words, where it's produced. And it's produced, obviously, for the most part. I say for the most part, because this is also a bit under discussion. For the most part, it's inside the ventricle. So maybe that is the more physiological solution, obviously.
No, these are
addressed in your technique.
Yeah, excellent point, Martin. And I agree with you. We don't completely understand the CSF fluid dynamics, even the ventricular size and the relationship to. I think these are excellent points that you're raising, and the issue with traversing into the ventricle, it may be possible to perform that from a transcisternal approach, hopefully. It may be possible to do what you're saying, which is to perform surgery and place a catheter and then have it drain into the sigmoid sinus.
And just do a bit of drilling and expose the sigmoid sinus at the angle of transverse and sigmoid sinus, and that's it. I mean, we have, that the jugular shunts and the cardiac shunts, they have been going out of fashion somehow because it's a bit more difficult to get to the jugular vein and then puncture it properly. And some people used to use the facial vein, but then that was also, and so, whatever will be easiest, like your technique obviously is very elegant. But it also means that you have a very dedicated neurointerventionalist, which is, I can promise you, they're not available and for the foreseeable future will not be available unless the surgeons become more involved and become interventionalists.
Yes,
something
I think, the point you raise is excellent. I think the workforce is very critical, and of course, it's very different from one country to the other. In the U.S., we have both interventional neurosurgeons, interventional neuroradiologists, interventional neurologists working, because we have had to treat stroke, embolic stroke, and LVO. Pretty much every center, even smaller hospitals now have the ability to have an interventionalist. And so the workforce in the United States is less concerning, but you're absolutely right. In other parts of the world, that is still a work in evolution. With respect to the surgery, I think the thing we worry most about when accessing surgically the sigmoid sinus or the transverse sinus is blood, control of any venous bleeding, use of hemostatic agents, what is the effect on the local sinus. And the beauty of the inferior petrosal sinus, it is redundant. And, a lot of times in carotid cavernous fistulas, we are able to coil occlude it. Whereas if there was any compromise to the sigmoid sinus or transverse sinus from a direct surgical approach, that may be less well tolerated.
I would think that's less of a concern, once you have the venous wall exposed properly, you have it in front of your eyes and you can it. The complication scenarios of what I just mentioned as a possible future approach would be different, of course. There will be different, people sinus, but then, we do this for other posterior fossa surgery all the time. So I think those who are, I mean, that's a teachable thing, actually. I should think it's not too much of an issue. Anyhow, I don't want to hold up the whole meeting, and thank you very much for your excellent presentation, and we look forward to hear more from this.
Thank you very much, Martin. I appreciate it. Thank you for
Dr.
the.
Malik, actually, I have a question. Can you just directly put the e-shunt into the ventricle, maybe like through the brain? Like,
Yes, we have some IP intellectual property about different ways to place it in different locations, but we have not really approached that, mostly because of the concern for traversing smaller veins, or the concern for going through parenchyma, and so. But yes, the approach and the device itself, the very same device, could be used for placement in other parts of the brain, where you are able to connect the cistern or CSF containing space to a venous element, and that includes potentially even on the spine.
thank you.
Thank you. I think there was a question by Human Lee about does the tube have anticoagulant coating? It is coated right now with a heparin coating. Yeah.
Okay.
Okay. Thank you very much, John and Human Lee, for the invitation, and it was really a pleasure. And I apologize about the audio issues. I hope the major points of the talk came across.
Thanks a lot, Doc. Great. Okay, Wan Lee.
Yeah, thank you again, Dr. Malik. I hope to see you again the next time, maybe in China again.
Hope so too. Thanks, my pleasure. Thank you.
Now let's we move to the second speaker. Will be Dr. Wang Jun from Nanfang Hospital, Nanfang Medical University. He will talk about another interesting topic about the neural network surgery. Okay, please, Dr. Wang.
Okay, thank you. I'll share my picture. Oh.
You can share your screen, right?
Okay, I tried. Is that okay?
Yes, okay, yeah.
Okay.
You want to make a full screen presentation mode? Do you know what I mean? Presentation mode.
Presentation mode. Oh, okay.
Yeah. Can you show him? Yeah, make a presentation mode, please. Can you explain to him, Wan Lee, where to do that?
Is that okay?
No, it's still.
Yeah, 你用一个全屏模式，就是点一下那个播放的箭头。
Okay. It's still not okay. Oh.
No, you did it before. No, you remember you did it before.
Your mouse, yeah， 你就点一下那个箭头嘛，全屏播放的模式。
Press F5. Press the key F5.
This one.
这不是有一个显着放映嘛？你点着放映，它就放出，就是那个菜单上。
Okay. Is that okay?
No.
No.
Under this. 最下面，箭头往下。
This one.
对 ，press.
Is that okay? No.
No.
Never
Maybe
mind.
just, that is okay.
Do you have PowerPoint?
Yeah, this is PowerPoint. Is that okay? It's not okay.
No.
No.
No, maybe I can show it like this one. Okay.
UPS 应该用那个 PowerPoint。
PowerPoint. You can press here. 当页开始。上面。
你都移到那儿了，它显示从头开始，你就开始。你刚才都已经弹出那个菜单。
这里。
对呀，
是吧？
这不是这个开始吗？你得一下，你又跑了。你用鼠标。
鼠标是这样吗？对不对？这里是吧？
对呀。
我点了之后它就跑了。
所以你这个 PPT
不行，那就这样吧，就这样 OK 吗 ？OK。Can you see my PPT?
You can just continue. Never mind. Yeah.
Yeah, that's okay. Just go ahead.
Okay, thank you. I'm sorry for that.
That's
Good
okay.
evening. Okay. Good evening and good morning, everybody. It's my honor to take part in this great series webinar, which was organized by the Chinese Neurosurgical Journal. I'm Dr. Jun Wang from Department of Neurosurgery, Nanhua Hospital, Southern Medical University, one of major neurosurgical center located in Guangzhou, southern China. Today's topic will be focused on neural network surgery, which was initiated at an undergraduate student program on March 2019, about 4 years ago in Southern Medical University. Today, I'd like to deliver the presentation on neural network surgery. The next is coming. I will try to lead the program. I'll try my best to make a glimpse of the background and history and the definition of the neural network surgery, followed by the the major component of neural network surgery, and at last, the outlook of neural network surgery in the future will be discussed. As we know, the neuromodulation surgery for functional diseases, such as epilepsy and Parkinson's disease, have been proved effective, but its main mechanism lacks a reasonable explanations. On the other hand, low-force theory cannot explain symptoms caused by the combined effect of multiple brain regions, and the local surgical strategies cannot accurately predict the effect of treatment on an individual basis. As we know, the masterpiece works from the biological neuroscience and computer science have obtained. For example, on the picture like this, mapped the synaptic resolution connects of an entire insect brain, the dwarf larva, with rich behavior, including learning, value computations. Brains contain networks of interconnected neurons. So know the network architecture is essential for understanding brain functions. But we didn't have any direct evidence from the human brains. On the other hand, the computer science mimics neural networks design program also require for understanding of neural networks. When designing artificial neural networks, researchers do not craft the specific computation performed by the networks. Instead, they specify these three components. That is, the object functions, quantify the performance on a task, and learning involves finding simultaneous ways to maximize or minimize the objective functions. With the growing success of deep learning, which utilize brain-inspired architectures, these three design components have increasingly become central to how we model, engineering, and optimize complex artificial learning systems. That is, Regarding on clinical and the neuroscience and the computer science, there's no direct evidence from the human brains. But at the same time, their master works were obtained from the biological neuroscience and the computer neuroscience regarding on the neural networks. So the theory of so what's the history of the neural network surgeries? I have tried to have a glimpse history of this. The theory of diffuse neural networks was first proposed by George Galach. And Gauge itself a chronological method first observed existence of nerve fibers. But when there's at that time no gap was observed by the Gauge, so therefore he became forms part of the diffuse neural network doctrine. But Kaha refined Gauge as a standard method and observed that nerve fibers were not directly connected. So he challenged the radical theory and proposed that nerve cells can be independent of each other. Convinced by the object evidence provided by Kaha and others, William Van Wyder proposed the name neuron and formally established the neuron doctrines, which was based on the Kaha and the colleagues' work achievements. Individual neurons can be clearly seen under the electric microscope in a letter, which confirms the structure connection of neural theory. However, the theory of diffuse neural networks supported by Gauges holds that a complete neural networks in the precise and basis for realizing various complex functions, which is algorithm at least in the functional aspects, but no one has confirmed its structures. What a stunning! Gauge and Kaha share the Nobel Prize in Physiology or Medicine 1906 regarding on their great contribution in neuroscience. A three-dimensional analysis of the article published recently in the journal Science shows that internal neural networks of neurons form a continuous network of membranes rather than connecting through synapses. This shows that neural network not only has functional rationality, maybe, but also has structural rationality. In detail, we see this in detail. The more detailed works shown in these articles, as in the primary figure 1, the multiple nucleotides extending from one some are interconnected through analysis and thus form an extensive continuous network within a single nerve net neurons, like this. On primary figure 2 in this science articles, whereas gap function could readily be identified with cone plants, as in figure S1, and the authors detect neither electric nor chemical synapse between the cells of the SNN. So the neural networks and computer science, as we know, the originally inspired by neurobiology is deep neural network models in computing have become powerful tools for machine learning and artificial intelligence. That is at present. In turn, deep neural networks provide abstract process model of biological neural networks. However, it is still a difficult problem. But the neural network designed by the program can simulate the complex running process of the brain. This is the neural and computer science. So recently, the godfather of AR, the artificial intelligence, Scott Helton, resigned and expressed his concern about artificial intelligence based on neural networks. He concerned the internet would be done with fake photos, video, and text, and ordinary people would no longer be able to know what is real. But but our concerns are different from this, from his. As we know, as we show, that there are great achievements in clinicals, and the master works achieved by biological neuroscience and computer science, but the direct evidence of their results in human brain is unknown because of the ethical restraint. So, well, first and foremost, no known methods can direct measure activation of connections in the living human brain, because of the ethical risks. Instead, reason indirect approaches that project the functional signal from cortex onto the white matter. The brain diseases such as epilepsy and Parkinson's disease, that is functional neurosurgery, amplify our cognitive neurobiological body by disconnect brain networks. At present, neuromodulation surgery is the first line for the deep brain stimulation is as the first line treatment for the functional diseases. This is minimally invasive and reversible. So the patients, like the Parkinson's disease, require and needed the modulation of neuromodulation, and the deep LS, the neuromodulation including deep BS, deep brain stimulation, and RNS are minimally invasive and reversible that give us the neural networks to be applied to the human brain in clinical scenarios. Therefore, ideally, the neuromodulation for treating brain disorder, ideally, clinical treatment using neuromodulation should be based on the acknowledgement of the specific dysfunction neurons and circuits underlying a particular brain disorder, a scenario largely unattainable at the present. Given the individual variation in cranial anatomy and neurocircuit configuration, it is desirable to have quantitative simulation or measurement of the effect of modulation on the brain of each subject in order to achieve more precise and effective neuromodulation. For example, this recently a paper was published by Professor Chou and his colleagues, but analyzed in the RSF-FMI datasets of 1,000 major depressed disease patients and over 900 health controls. Professor Chou at Southern Medical Unit found that MDD patients and the specific mice showed highly consistent challenge in depression-related networks, especially those associated with MPF. But the direct effect on MPF in human brain is unknown. This is unknown. The direct effect of MPF in patients is unknown. What's more, recently the China Brain Project from bench to bedside was initiated. This solid foundation in basic research, cutting-edge technology in brain-inspired intelligence, and large database platform of human brain health empower the progress of China Brain Project. Although there will be many challenges in the future, we look forward to breakthrough in China and its contribution to the global brain research. Based on the above materials and evidences, we attempt to define the neural network surgery at the present. That is, maybe the neural network surgery, this definition may be not perfect, but we propose this as at the present what we got to know. That is, the neural network surgery apply updated knowledge or investigate neural networks that is from the biological neuroscience and computer science, and the precise brain images that will fit the brain, the human brain anatomy to the individual the structures of which was investigated in clinical, in biological or computer neural networks to draw neural networks and look at key targets in the process of solving. In the process of solving clinical problems, it used neuroengineering to modulate the transmission of the neural signals and characteristics of neural networks. That is, we mean the electric, like the DBS, and the magnetic or the chemicals, that the neural transmitters, exploring the feasibility of individual reconstruction of the brain based on network neuroscience and computer neuroscience. Sorry for the expression of my language. What I want to say is our team tried to draft the primary definition of neural network surgery based on the up-to-date evidence and the masterpiece of from the clinical scenarios, as well as from the biological neuroscience and the computer neuroscience. This is the application of neural network has a solid foundation in clinical practice. It has been proved that it can intervene, measure, regulate, and analyze. This is aspect of neural network surgery that we proposed. That is, it can intervention, measure, analyze, measurement, and construction in different clinical scenarios, and has been used in many diseases. These are thousands of papers were published based on this. Apart from the Parkinson's disease, with the treatment of DBS. DBS leads maybe to different motor disorders like the tic improvement. This are the DBS maybe modulate the different neural networks. And out network topology in temporal lobe epilepsies, in like this one, in which was published in 2022, and the group analysis of the this is Parkinson's disease, and the neural published on the brain stimulation and the neural image. There are thousands of articles related on different diseases. Like the apart from the functional neurosurgery, the schematic aspects of different image or image modalities were also investigated in the brain tumors, like the gliomas, like this one, and the network science approach to brain-computer interface, like this one. These are other examples of the neural network surgery application in clinical scenarios, including various disorders. For example, the Parkinson's disease epilepsy and the brain tumors like the gliomas, and also the brain-computer interface, that is BCI. Therefore, the complication of the clinical neural was summarized in many clinical scenarios, as shown in these pictures. We can test neural net first, and at the same time, we can combine engineering with clinical interventions to treat patients and cover clinical research and translations. These are the next part is the patient care. This is the Parkinson's disease as we issue this.
这是你平常的状态还是差的状态？还有啊，动不了，你能起来吗？能起来吗？动不了。这是你平常的状态还
Don't
是？
know where we're getting that. Once
can get it.
again, I don't know where we're getting that audio from.
Can you see this?
Yeah, continue, please.
Okay. This is where I show that the patients can benefit from the neural net surgery in clinical scenarios. As this is the Parkinson disease benefit from the DBS, but the underlying mechanisms are unknown. So we try to know the neural network surgery in this clinical scenarios. This is the examples. In another, the neural nets can be, include the talent educations that we know. For the purpose of neural net surgery is undoubtedly the crown of neuroscience to train modern neurosurgeons and reserve talent for the development of various basic disorders. As we show this, we can show this. Up to now, we have tools. Up to now, we have so far the neural net surgery team has held 6 sessions and counted many outstanding talent for the future neurosurgeons in other departments. There are we show on the research and the translation. The third aspect of the neural networks is the research and the translation. We regarding on the neural network technology, we can do various research. For example, we do this is DNT, and we use the radiomic analysis. We use this and was started by our colleagues in the United States. This is one example is the research. And for the translation, we do another technology modified to the deep breathing stimulation as we show. We do this. This was published on 2019 and was viewed and focused by various local universities all in the world. So therefore, the neural networks integrated clinical treatment. That is the patient. The clinical that is the patient care and the talent training and research and the translation in multi-strat and complex ways. That is what is we show the 3 major components of neural network surgery: that the patient care, the talent education, and the research and the translation. Just as usual, Zeno through a vast different, but he has no haven't seen this these animals, but he pictures this shows the people's what is the rhino is. We also haven't seen the whole picture of neural network surgery, but what we do is try to describe through the available evidences. So we haven't seen the whole picture of neural networks, but try to describe it in through the available evidence. Maybe that can give some indications for the for our college and the income future. So this is our team, and thanks for your attention. If anybody have any question, can ask. Thank you.
Okay, thank you, Dr. Wang, for your nice presentation about the neural network surgery. Okay, are there any questions from the audience? Let's see.
Yes, quick question. I really enjoyed your presentation. It's absolutely wonderful. What are your thoughts about applications of this work on the brain-computer interface, specifically also using endovascular approach?
Did you hear the question, Juan?
Dr. Wang, can you hear the question from Dr. Malik?
Sorry, can you re-ask it?
Sure, no problem. I really enjoyed your talk. It was excellent.
Thank you.
And I was wondering what are the implications of your research on the brain-computer interface and also the endovascular aspect of that?
Endovascular. Okay, you
for instance, like the synchron approach.
Oh, you want to say my comments on the brain-computer interface? Yeah. Okay. Thank you. That's very good questions. That from my point of view, regarding on the neural network surgery, the brain-computer interface just the start of the neural network surgery, because as we know, the source of information is from the brain context. Okay, you got it. Okay. The source of the information is derived from the brain context, so that the brain-computer interface just link the brain context to our arms or the robotics. So that may be the primary, the pre-first or the pre-stages of the neural network surgeries. Okay. Because the source of the information is derived from our brains, not from reconstructing it. Okay.
Thank you.
So Dr. Malik, is that endovascular, the brain and machine interface technique available in your hospital? I read the paper about that.
Yes, it's an excellent technique that has been, it's on a trial in the United States. My hospital is not currently participating, although we are interested. But there are a number of US hospitals that are now enrolling patients. I think they had 4 patients in Australia that did very well, and so now they're starting US trials. But we are unfortunately not part of it at this point.
That's very good.
I read the paper and saw they used the stent with the electrode to treat the Parkinson's disease, right?
Yes, they are trying to actually use it to capture some motor signals. So it's a very unique, congratulations to their team at Synchron. So we're all looking forward to how they progress.
Interesting. Thank you.
Interesting. Thank you.
Okay. Are there any other questions or comments?
Akashi, do you have any comments or questions?
Thank you. I'm Dr. Takashi Kon from Tokyo, Japan, and thank you for Dr. Adam, wonderful speech. And I would like to ask you to Dr. Adam Malik, so about the e-shunt system. The shunt system would be very easier and very effective. It seems to be very effective, but I have no experience. So, is there any complications of breaking the veins, or complications of bleeding, venous bleeding, or shunt system? Shunt system, usually we use the ProGab system, and the shunt adjustment is needed. So the pressure adjustment is how do you manage the pressure adjustment or and the venous bleeding?
Thank you very much, Professor Gon. So we have not encountered any venous bleeding, and we are very pleasantly surprised that, even though we have traversed the Dura over 25 times, we always get a cone beam CT right on the spot, and then after there has been no bleeding in the brain or in the cistern. And again, I think that's because the pressure gradient, unless when we're calling an aneurysm, the pressure gradient is very high pressure out, and then in this case, it's the opposite. We kind of did not completely anticipate that, but it was a very positive finding. We had similar experience in the venous sheep experiments where we traversed through the trochlea and then also did not encounter that problem. The other question that you have asked, which is excellent, is any injury to the veins. We have multiple studies on follow-up showing that the inferior petrosal sinus actually remains patent because it's a small tube that goes through it. But the bigger question you have is the whole concept of adjustment of the valve. And at this point, as I mentioned, our valve acts mostly on a pressure gradient. So theoretically, if the patient has hydrocephalus with very, very low pressure and our current implant, what's called the cracking pressure, above which there's a threshold that you need to exceed for the valve to open. If that cracking pressure is higher than the patient's very, very low pressure, then of course the device will not work. But clinically, as the case that I've shown you, that does not seem to be the case. And I think, as Professor Martin mentioned, we don't understand the variations during the day when you stand up or bear down or cough. If at any time, if those events, the pressure exceeds then you will release some CSF. So these are all questions that we don't completely have the answer to, and we're mostly looking at the clinical outcome. For the subarachnoid patients, that meant ability to maintain pressure for 36 hours to enable EVD removal, the clamp EVD. So all 8 patients have passed that. And for the normal pressure hydrocephalus, as you can see, it's a clinical outcome. Most patients seem to be doing very well. But again, we have a stringent requirement for improvement of the gait by 20%. So it will remain to be seen if we change that, and if we start employing it more widely, whether we will get still the same results, or whether we will need to modify the valve to a lower pressure. Theoretically, down the line, you could have envisioned some micro MEMS or machining or some kind of a micro electronic technology that you can regulate it from outside, but that is way in the future, I would think.
Thank you. Very good. Thank you. Understand. So I'm looking to the paper of the Cerebask and further expected further study. Thank you.
Thank you, Professor.
Okay, thank you. Okay, so I think it's time at 9:30. I think we can start. We can finish this this webinar right now.
Okay, very good. Very good, Wanli. Thanks a lot. Thanks, Dr. Malik. Thanks, Dr. Wang. And thanks, Wanli, for putting it together. I'm sorry, Ben Zhu is on his plane in Malaysia. He connected briefly, but not continually. Anyways, next week we have Demetrius Lopez. He's a neurosurgeon from, not next week, in 2 weeks. Demetrius Lopez, a neurosurgeon from Chicago. He's going to either lecture on strokes or AI and neurosurgery. He does a lot. So, okay, we'll see you in 2 weeks. Thanks a lot, everyone.
Thank you.
Stick around. I'm just going to go off air.
谢谢。